When we talk about immunotherapy, a lot of times patients will always say to me, so what exactly are you talking about? You know, are you going to take cells from my body and give them back to me? So how do you frame it for your patients to explain the mechanism as to how anti-PD-1 therapy in squamous cell works?
Surely. So yeah, I think it's an interesting concept that they're not always ready to fully understand, but it's something that piques their interest. I do tell them that there is a reason why immunotherapy has been tried for squamous cell carcinoma, because it's a type of skin cancer that has a high mutation burden. So there's many mutations that are found in these cutaneous squamous cell carcinomas. And because of that, we can sort of harness the power of the immune system to try to recognize it as foreign and then attack it. And mainly the squamous cell carcinoma acts through this PD-1 pathway to actually evade the immune system and to hide from it. But by using these type of immunotherapies, these PD-1 inhibitors, we can actually stop that evasion and actually get the immune system to hopefully recognize that skin cancer and destroy it.
Yeah, I think, especially now in the COVID age where everybody is home watching TV, I usually explain, I think every patient has seen Independence Day.
Oh, true.
And so I liken it to Independence Day, where the squamous cell cancer is the alien ship and it's got its protective force field around it. And our T cells are really those fighter jets trying to attack it. And until we give them PD-1 and figure out how to break through that force field, I liken the PD-1 to putting holes in the force field so our T cells can get through and kill that mothership. And everybody does wow, that really makes a whole lot of sense because everybody's seen that movie. So I think that's something I like to share with my patients because it helps them to better understand the mechanism on a more simplistic manner so that they can go home and share that with their family.
I like that analogy. I might use it.
Well, Star Wars is making a comeback, so I sometimes use Star Wars and the Death Star, but Independence Day, everybody kind of gets that one. In treating patients with anti-PD-1 therapy, namely cemiplimab, based on an every 3-week schedule, do you have any issues with your patients keeping on that track, staying on schedule because of toxicity? And when do you start to look for response? And when would you actually say, yeah, I don't think this is helping? Or when would you expect to see a clinical response once you start immunotherapy?
So I would actually put this question back to you. I usually partner with my medical oncologist. So we work in tandem. The medical oncologist is prescribing the medication, and we're also seeing the patient in tandem, not to overburden them with visits, but just to make sure that we're seeing a clinical response and that we're not seeing anything new pop up in the area as well, any new skin lesions of that sort. But we really rely on our medical oncologist to help us with this. We can definitely provide a more clinical response, to see how the tumor is shrinking. But I would ask you that question: how do you see them?
Yeah, we try to do the same, working in conjunction with my dermatologist, who also becomes very helpful to me as well if the patients were to get any cemiplimab-induced rashes. So, everybody's on the same page. I think patients do exceedingly well, don't deal with a whole lot of toxicity, so they're not immunocompromised. They don't really feel that fatigued. They're not dealing with the same cytopenias that we see with chemotherapy. Clearly, for me, the biggest complaint of most patients is really itching and rash.
Mm-hmm.
And that is not usually a reason to hold a patient's next therapy. You can usually manage it in the interim. get it under control and keep people on schedule. How many cycles? I think that's really an individual question, because I've seen some patients have a very dramatic response after just one cycle where I know it's working. So I feel confident that we're moving down the right path. However, there are some patients where I'm just not really sure. And so I'm very compulsive about taking measurements of the lesions every time the patient is in the office with photographs. And I think clearly if the patient has not had any response within 3 to 4 cycles, I'm calling it a day. And if I see the lesion growing, I'm gonna also, raise the flag a whole lot sooner and say, yeah, I don't think you're benefiting from this therapy.
Yeah, I think that's super important, because it is a sort of evolving decision, as the patient is being treated. We're always looking for response. And if we're not seeing that and we need to move on to something such as either a surgical or radiation intervention, then we have that time to do that and we're acting quickly enough.
Yeah, I think that's so important not to lose that window of opportunity to move on to something else.
We often get called as well, like you were saying, for evaluation of any rashes that happen while on immunotherapy. And we really try to be cognizant of how the patient is doing as well, especially if they're getting an advantage from the immunotherapy and they're responding. So if the patient's comfortable enough, we sometimes can treat through these rashes with either topical corticosteroids and or antihistamines. Sometimes we do actually have to give oral steroids as well. I was wondering how you feel about that, if you think it dampens the response or you try to avoid oral steroids in these patients.
I think it depends on the degree of the rash. Clearly, I always try the topical hydrocortisone creams, oral antihistamines, Pepcid, Benadryl, Claritin. But sometimes when people start telling me that they can't sleep at night because they're up itching all night, that's when I decide, okay, it's time to give them a short course of steroids, oral corticosteroids. So sometimes a Medrol dose pack for just a short course of the 6 days will be sufficient. But depending upon, is that rash being coupled with, where the itch being coupled with a diffuse rash, I may opt for a 2-week prednisone taper, a little bit of a higher dose, followed by, a decrease every 3 to 4 days, so that by time they come back for their next cycle, they're really off all corticosteroids.